Good afternoon, and thank you for staying. My name is Karen Chivers, and I'm also on the Trainee Consultant Practitioner programme, and my background is nursing and emergency care. And I'm just going to take you through some of my experiences in the last 18 months. So, as always, we're going to talk about the 4 different domains for expert practice and consultant practitioning. So within my expert practice, I again have to go through those RChem competencies. I've seen a wide portfolio of patients, both within the emergency department and the pre-hospital environment. And I've been fortunate so far to do a placement at the John Radcliffe in the emergency department and a placement pre-hospitally with South Central Ambulance Service, looking at the interface between pre-hospital and hospital patient care. The RChem portfolio is vast, and it's going to take a little while to get through it, but I'm ploughing through it and providing evidence of the patients that I have seen, that I can see both clinically in the hospital but also out of hospital. And I've grown in confidence in assessing and managing these patients. And I think the real way that that's shown is by now having a plan for the patient and then saying to a doctor, this is what I think, and they'll say, yeah, you're right. Whereas before it would be, I've seen a patient, can I run the patient through with you? What do you think? So now it definitely has turned around. And I've grown in reflective practice. I'm using reflective models that I didn't really know existed. And I've now sort of come to the stage where actually some of the reflective models aren't that great for the role that I'm in, because they don't allow enough time for me to be analytical and actually understand more about what I'm doing. And I've also educated both clinical and managerial staff about my role. And I really wish I had a tape recorder sometimes to say what it is I do. There's a lot of confusion, especially in the emergency department, where we now have trainee advanced clinical practitioners. Whereas 2 years ago, they didn't really exist in the emergency department. So consultant practitioners, consultant nurses were the only thing there. So it's been a constant. But we're getting there. So education and training, I've delivered quite a lot of formal and informal training sessions. I've completed my non-medical prescribing course. And as Freya said earlier, this is absolutely imperative to my role. I can see patients now and actually I can prescribe their treatment. So it encourages the patient journey to be that much quicker. I've completed a safeguarding leaders course, having more understanding. I knew patients had safeguarding issues, but I'd pass them on to someone else. But now actually I know the channels that I need to follow to get that information across. I've directed ATNC course, and for those of you who don't know, that's the Advanced Trauma Nurse course, and I direct that once a year at Wexham Park. But now I've started developing a little bit more in my journey with trauma as well. And this year, just 2 weeks ago, we had a course that was successful, but I actually had a co-course director. So actually developing his skills to be able to become a director of a course in the future. And that's quite a big step. And the other thing that I've also done with the Advanced Trauma Nurse course is I've recently been appointed as Vice Chair of the ATNC steering group. So that will mean that I will have much more of a national focus and a presence in ATLS meetings as well. I've taught on advanced life support courses, which has been great because it just keeps you up to date, and I actually thoroughly enjoy them. And I've commenced a doctorate in clinical practice, and I'll come back to that in a short while. So leadership. Probably for me, I've been a senior nurse for quite a long time. I've been a Band 7 for 15 years. And why have I stayed at Band 7? I love my clinical work. I don't want to be a manager, I want to be really clinical. So for me, the consultant practitioner programme is ideal, with 50% of my time still clinical. But I recognise that actually I still need to have leadership skills. So for me, this has been a massive growth. I've had discussion with senior staff within the hospital and actually understanding their roles and how that impacts strategically on the hospital, but also on the wider organisation in the community too. I attended an NMC hearing and I reflected on this case, and it was very formal and it was very scary. But for me, it was more about the process and actually being able to support people if they did have to go and give evidence at one of these hearings and knowing what to understand. And more recently, I also went and attended an inquest. And again, it was about the process that happens. Very scary. I've attended a Lead and Be Led course, so looked at the skills that you need to be a good leader. And with that, we did the Myers-Briggs training and analysis. And that was fascinating. Didn't really give me many surprises about what my type of person was. However, what it did make me do is think about how I manage my type in meetings and how I manage myself and have to come out of my shell. And more recently, I was at a conference and I hate putting my hand up and asking a question. I thought, I need to do this, I need to do it. And I did it, and it was fine. However, if you'd have told me a year ago that I'd do that, I'd have said, no. I'd have just been that frustrated person that didn't ask the question that someone else asked. And I've demonstrated that I've got leadership in relation to quality improvement projects and how they've been managed. And I'm currently awaiting the results of my 360 degree appraisal. So quality improvement is the area where I want to spend more time on this journey. I've successfully completed 2 quality improvement projects, and I'm on my 3rd, and I've had a positive outcome. And there's 2 posters. There's one blocking the pain just there, which I'm going to talk about in more depth, and there's another one here called Ready and Waiting. And the Ready and Waiting poster was the work that I did on pre-alerts and empowering clinical staff in the emergency department to take charge of taking that pre-alert call before the patient arrived in the hospital. And I did that with a lot of work with the ambulance staff as well as the hospital staff, so it became very much a collaborative process. And it's still going okay. They do need a bit more teaching, but that's obviously the risk when you're not there to reinforce it time after time. And sustainability, I really realise, is where I need to improve on. So I've undertaken training on quality improvement methodology, and I've utilised this in my projects. Again, it's terminology that I was not familiar with. And I know from previously we talk a lot about change management. That's great. I knew about Lewin's change management. But what I couldn't have told you is how actually to make those changes and make sure that they could actually be implemented safely and for the benefit of the patient with really underpinning knowledge. I've taken an investigation process and presented at a governance meeting. Challenging. And I've gone on further to do another investigation, which was even more challenging. And that became challenging because of meetings with the family and wanting to do it right for the family. Still learning. I'm very much still learning. And I've submitted an abstract and presented at a conference. And I actually went to Barcelona and presented at International Emergency Nursing and Trauma Conference. And that was really helpful because what it meant is I could network with other individuals. So I met people from Sweden and Australia who were really interested in my project, which is great because it means other people are as excited as I am. So the project I'm going to talk about is Blocking the Pain. So Blocking the Pain came about because I know that patients every day attend the emergency department with a broken hip. They fall and they fracture their neck or femur. And they're in pain. And the journey for patients in pain is a long one. And as Spencer said earlier, often these patients can be on the floor for a length of time before anybody arrives. And then an ambulance may arrive and they get admitted to the emergency department and then they have an x-ray and then we think about pain relief. That time period could be 2 to 4 hours of no pain relief. And it's quite demoralising to think that patients are in pain for that long. They then get admitted to a ward where you think pain relief becomes a bit more regular. But in one of the audits I did to start with, it was up to 20 hours for some patients to get to a ward. So we're on a trolley for 20 hours. So what I wanted to do was think about how we could change the process. Why were patients not getting pain relief? And that really, the NICE guidance recommends that patients have what's called a fascia iliaca block, hence the title, Blocking the Pain. And this is a regional anaesthetic, and it gives them effective pain relief for up to 12 hours. But why were blocks not being performed? NICE recommends that that's a really good practice. But actually, there weren't enough people that could do it. So, quite a simple solution. There needs to be collaboration with medical staff. We thought about developing a policy and increased awareness of pain and pain score. So I developed a competency document which actually had the policy in it. It also had documentation to review the competencies that could be ticked. And the form that I used was called a direct observational procedural form, which actually is used by medical staff. and medical staff were going to be the people that signed this off. So actually, they needed to be familiar with the documentation, and that worked really well. So we said, actually, we could increase people getting blocks by increasing the number of people who could do it. It's rocket science. So nurses, why could nurses not give blocks? There was no reason. They're a safe procedure to do, and there are limited side effects. So with collaboration with the clinical director who agreed, go for it, okay, we started training nurses. Now initially my thought was actually we should have a cut-off, we should be band 6 and 7. But the matron was very, very keen that actually we taught everybody. I was a bit like, I'm not so sure. However, what she wanted is everybody to have the training about what a block was, so it increased awareness amongst staff, so that actually people thought about it. But it's only the 6s and 7s that were being trained to actually instill the block. So the improvement aim, so fractures with a hashtag NOF, so fractured neck of femur, were in pain for too long. And we could train these nurses to give blocks in a timely manner. And hopefully by December 2015, which was when the project was in its throes, 80% of those patients that were eligible to have the block could have the block. Now, interestingly, one of the sort of going through a plan, do, study, act cycle, one of the key things was, it's going to take too long. And that's always like, we need to be cutting our time down, we need to be doing it efficiently. But actually timing how long it took somebody to get the drug keys, after getting a prescription, to get the drug keys, to find somebody else to check out the drugs, which would be opiates, so they'd be locked away, getting the drugs out, drawing them up, getting to the patient, checking the patient, making sure the other nurse was with you, and administering the opiates. Took about 10 minutes on a good day. Other days it was longer. To instill the block takes under 10 minutes. So immediately there was some progress there. It's not going to be actually any more impact on our time. So my reflections and learning, there's been lots, and still it continues, even though I'm not there with the project anymore. What has happened is there's increased awareness of patients' potential pain need, and actually for early analgesia. It's got increased knowledge about the options of pain relief. It's not just a block. We can give IV paracetamol, we can give morphine, but actually a block is so effective. And we've collaborated. And one of the real positives for me was that the document that we developed has now been adopted by medical staff, and their trainees also use the same document to prove that they're competent. But that's the first time for a long time that that's happened. And the best outcome is patients are in pain for less time, and that actually has to be a major positive. So the impact on my organisation of me doing this programme is massive. They're going to have a confident practitioner in 4 domains. So when I go back to my host organisation at Wexham Park, and I'm looking to my manager over there, they will hopefully create a consultant practitioner post for me to work in the emergency department. And I can translate what I've learnt into clinical practice. And all the time, by networking and talking to people, I'm raising the profile, not only of myself, but representing the organisation that I work for. And I'm looking forward to developing the role in the future. So the first 18 months has been a lot of twists and turns. Sometimes it's been overwhelming with the amount of work that's had to be done, but there's been so many opportunities, and my learning has been immense, and actually it's made me more resilient as a practitioner. Thank you.